Welcome back, rheumatology fans. Fibromyalgia puts the fear into many healthcare professionals. Some don't believe it exists, and some think it's diagnosed by poking people all over. Wherever you fit on this spectrum is definitely increased in prevalence in rheumatological conditions, so let's take a look. Fibromyalgia. Very briefly, fibromyalgia is clinically diagnosed pain disorder lasting at least 3 months with sleep disturbance and cognitive effects. Blood testing and imaging is typically normal, and there is a lack of a better explanation for the symptoms. Prevalence is estimated to be about 2 to 7% of the population. I also discussed fibromyalgia diagnosis at length in one of my most popular webinars to date. You can find that on the YouTube channel. It's called Fibromyalgia Diagnosis. How is it diagnosed? Snappy title. It is outside the scope of this particular article or webinar to discuss all the associated issues people with fibromyalgia or with possible fibromyalgia face, but they do include clinician belief systems, healthcare restrictions, societal stigma, and a lot more. Fibromyalgia prevalence in rheumatological disorders. It gets a bit complicated here because many rheumatological diseases share demographic factors with fibromyalgia. Both are typically female predominant, aged 30 to 60 at onset, sleep disturbances, widespread pain. Extricating those who have developed secondary fibromyalgia and those whose rheumatological disease activity is continuing for an extended duration and satisfying the diagnostic criteria for fibromyalgia is really hard. Some approximate figures. Fibromyalgia is co-present in rheumatoid arthritis about 18 to 24% of patients, lupus about 13%, axial spondyloarthritis 13 to 16%, psoriatic arthritis 18%, osteoarthritis about 10%, and polymyalgia rheumatica about 7%. Those are significant numbers. Remember, 2 to 7% of the regular population. Along with the aforementioned overlapping demographic factors, the risk for developing comorbid fibromyalgia is disease activity. The higher the disease activity for longer, the more likely the person will develop comorbid fibromyalgia. This is no surprise at all. The more input to the central nervous system for longer periods of time, it's more likely to sensitize it. Consider fibromyalgia in rheumatological patients. Management might not be continued escalation of disease-modifying medication. It can be understandably difficult for people to be told their arthritis is not the cause of continuing symptoms that are the same as previous when the arthritis was causing those symptoms. So tread carefully.